Every year, I think it's something like 1.1 million people worldwide get diagnosed with colorectal cancer.
Yeah, that's right.
But the way we treat it now, for a growing number of those patients, it's just completely different. It's no longer about, just flooding the body with this massive chemical sledgehammer.
Right, exactly. We are really witnessing a total paradigm shift here. I mean,
Yeah.
the European Society for Medical Oncology, or ESMO, they just updated their clinical practice guidelines for metastatic colorectal cancer. And just reading through this data, the sheer level of molecular precision they're using is staggering.
That's wow.
We're moving away from just treating a generalized anatomical organ. Now we're basically treating a highly specific genetic code.
Well, welcome to the deep dive. For you listening, our mission today is to essentially shortcut your way through this massive ESMO master playbook.
It is dense.
Very dense. But we're going to decode these highly personalized, molecularly targeted strategies that oncologists are using right now.
Sure.
Because we're talking about a disease where up to 30% of patients present with metastases on day one.
Yeah, primarily in the liver and lungs.
Right, and up to half of all patients will develop them eventually.
The statistical reality is definitely sobering, but the tools that are outlined in these new guidelines, they offer this highly choreographed counterattack.
Which is what we're going to get into.
Exactly. It requires understanding the tumor's exact origin, mapping its genetic mutations, and, timing interventions with incredible surgical precision.
Okay, let's unpack this. To actually treat the cancer today, you first have to understand the molecular fingerprint of the tumor, right?
Right.
And the ESMO guidelines are just remarkably strict about how that fingerprint is preserved from the very second a biopsy is extracted.
Yeah, the engineering precision starts immediately down in pathology. The guidelines mandate that any tumor sample, it must be fixed in 10% neutral buffered formalin. But the window for this is absolute. It has to be no less than 6 hours and strictly no more than 48 hours.
Wait, a 48-hour hard stop?
Mm.
I mean, that is an incredibly tight window for a busy hospital pathology department.
It really is.
What actually happens to the molecular data if they miss that window? Like, what if they leave it too long?
Well, it basically scrambles the signal. Formalin preserves the tissue by creating these chemical crosslinks between proteins and nucleic acids.
Okay.
So if you underfix it, the tissue just degrades. But if you overfix it, say a sample sits in formalin over a long holiday weekend.
Oh, right, like somebody forgets it in the lab.
Exactly. Those crosslinks become so tight and extensive that extracting intact DNA becomes nearly impossible.
Wow.
And pathologists really need pristine DNA. They do this thing called macrodissection, where they physically scrape the slide to enrich the sample until it contains more than 20% tumor cells.
Because they're hunting for specific predictive biomarkers, right?
Precise.
The guidelines emphasize testing for RAS mutations. They specifically KRAS and NRAS exons 2, 3, and 4, along with BRAF V600E and DMMR, which is mismatch repair deficiency.
Yeah, and what's fascinating here is how these mutations fundamentally alter the entire treatment algorithm.
How so?
Well, RAS genes encode a family of proteins that basically act as molecular switches for cell growth.
Okay.
Normally, they toggle between an active and inactive state depending on what the body needs. But a mutation in that RAS gene permanently jams the switch into the on position.
Oh, no.
Right,
Yeah.
so the cell just constantly receives the signal to divide, regardless of any external stimuli.
So treating the tumor without this testing is like trying to use a remote control without knowing what brand the TV is.
That's a great way to put it.
Like if the tumor has a RAS mutation, it's like the receiver is blocked, the anti-EGFR signal just won't work.
You've hit on the exact reason the guidelines classify RAS mutation as a negative predictive factor. The EGFR is simply the antenna on the cell membrane, receiving the initial growth signal. So if you cap the antenna with a targeted drug, but the RAS protein inside the cell is already misfiring and telling the cell to divide anyway,
Blocking the antenna does nothing.
it accomplishes absolutely nothing.
And you'd be exposing the patient to all the toxicities of an anti-EGFR drug for zero benefit. I mean, we're talking severe skin rashes.
Yeah, severe acneiform rashes, hypomagnesemia, all for zero clinical benefit.
Man, that's rough.
Which is exactly why establishing the RAS status is mandatory before initiating these therapies.
Right.
And when a standard tissue biopsy doesn't give you enough DNA, or if the patient is just unfit for an invasive procedure, the guidelines endorse using liquid biopsies.
Oh, right. Analyzing plasma-derived cell-free DNA from the blood. The mechanics of that are just remarkable to me.
It's incredible technology.
Like, as tumors die off, they just shed fragments of their mutated DNA directly into the bloodstream.
Hmm.
So by filtering the patient's plasma, oncologists can figure out the RAS or BRAF status without even doing a surgery.
Exactly, non-invasively.
But isolating that molecular fingerprint is really only part of the equation, isn't it?
It is.
Because the ESMO guidelines make it abundantly clear that the physical origin of the primary tumor dictates its biological behavior.
Yeah, the geography of the colon is arguably one of the most critical prognostic and predictive factors in colorectal oncology today.
Which is wild to think about.
It really is. The guidelines draw this hard, definitive line between right-sided or proximal tumors, so those located before the splenic flexure and left-sided, or distal tumors.
Okay, wait, the colon is essentially one continuous pipe. Why would it matter so drastically if the tumor started on the right side versus the left side? I mean, a pipe is a pipe.
You would think so, but the answer actually lies deep in human embryological development.
Wait, really? Like from when we're in the womb?
Yes, exactly. During fetal development, the colon doesn't form as just a single continuous tube starting from one point.
No.
The right side of the colon originates from the embryonic midgut, but the left side originates from the hindgut. They eventually meet and fuse together, but they maintain entirely distinct biological identities.
So we're dealing with two completely different cellular lineages.
Precisely. They are vascularized by entirely different arteries, they have different nerve connections, totally different microbiome compositions, and critically different molecular profiles.
Wow.
Right-sided tumors are far more likely to be hypermutated, they harbor those BRAF mutations, and they often present with that DMMR status we mentioned earlier.
Because of this completely distinct biological soil.
Right, and because of that, right-sided tumors generally carry a significantly worse prognosis.
And I imagine that embryological origin directly impacts how the tumor interacts with targeted therapies, too.
It absolutely does. The guidelines explicitly state that patients with left-sided RAS wild-type tumors, meaning normal, unmutated RAS, they see a major survival benefit from anti-EGFR therapies.
Okay.
But if that exact same RAS wild-type tumor originates on the right side,
Let me guess, it doesn't work.
the benefit is marginal at best.
That is fascinating. So the clinical data basically complicates the whole traditional understanding of precision medicine.
It really does. Even when the DNA fingerprint looks identical on paper, that right-sided midgut environment somehow suppresses the efficacy of those EGFR inhibitors.
Man. So it forces the oncologist to just completely alter their first-line therapy choices based solely on anatomical location.
Exactly.
Well, because left and right-sided tumors behave like entirely different diseases, a solitary oncologist really can't make the call alone.
No, not at all.
You need a synchronized team to map out the strategy, right?
Yeah.
Especially when the disease is already metastasized.
Managing metastatic colorectal cancer requires a multidisciplinary team, or MDT. It's an absolute necessity today.
Who's on that team?
You have medical oncologists, surgical oncologists, radiation oncologists, hepatobiliary specialists, pathologists, all reviewing the imaging and molecular data simultaneously.
And that team approach is heavily emphasized in the guidelines for a specific clinical scenario, right?
Yep.
Oligometastatic disease, or OMD.
Yeah,
So we're talking about a patient presenting with maybe 1 to 5 metastatic lesions, typically confined to just the liver or lungs.
Yeah, OMD is sort of a transitional state. The disease has escaped the primary site, but it hasn't disseminated systemically everywhere.
Got it. It sounds like if you have a lawn with a few dandelions, you don't need to spray the entire yard with a weed killer. You can just dig up those specific spots.
That's a perfect way to visualize it. You send in targeted strike teams to dig up those dandelions.
And the guidelines refer to those strike teams as local treatments, or LT.
Right.
Surgical resection is obviously the gold standard, assuming they can get clear margins. But the MDT has alternatives when surgery isn't viable, right? Like, what if the dandelion is wrapped around a sprinkler head?
Exactly. When surgery is too risky, they deploy thermal ablation techniques like microwave or radiofrequency ablation.
How does that work?
A radiologist basically guides a probe directly into the core of the metastasis in the liver. The probe emits electromagnetic waves that agitate the water molecules in the tumor tissue.
Oh, so it just cooks it.
It generates intense localized friction and heat. It essentially coagulates and destroys the tumor proteins from the inside out while sparing the healthy tissue around it.
That is incredible. And then SBRT, stereotactic body radiotherapy, is another option they highlighted for lesions that you just can't cut out or ablate.
Yeah, it delivers highly conformal, ablative doses of radiation to a very precise target.
But what happens when the spots are too widespread? Like, say a patient has multiple liver metastases encasing a major vein. You can't just ablate all of that.
No, you can't. And this raises an important question about resectability. It's not just about what can be physically cut out, it's about what healthy tissue remains after the cut.
Right.
When a surgeon deems a patient technically unresectable, the MDT pivots to conversion therapy.
Okay, what is that?
They initiate an aggressive regimen of systemic chemotherapy combined with targeted agents with the goal of inducing massive tumor shrinkage.
Oh, so you're basically attempting to pull the tumor away from critical structures to convert an inoperable patient into someone who can have surgery.
Exactly. And the survival data for successful conversion therapy is really compelling. If you can shrink it enough to get a clean surgical resection, those patients have survival trajectories that look just like patients who were resectable from day one.
That's huge.
It is. But the MDT has to be strategic. Sometimes, even if a patient presents with easily resectable liver metastases right away, the team will intentionally delay the surgery.
Wait, why would they wait if they can just cut it out?
It's a strategy of acquiring the proof of time.
Proof of time.
Yeah. Metastatic disease is microscopic before it becomes macroscopic. If you perform a major liver surgery immediately, but the patient actually has rapidly growing micrometastases that just haven't shown up on a CT scan yet.
And cancer will just come right back.
Exactly, within months. So by starting with a few cycles of systemic chemotherapy up front, the MDT tests the biological aggressiveness of the disease.
Oh, I see.
If the tumors remain stable or shrink, you've earned the proof of time, and then the surgery proceeds.
That makes a lot of sense. So whether they are striving for conversion or dealing with a disease that is just too disseminated for local treatments, the medical oncologist really takes the lead with systemic therapies.
Yes, the systemic cavalry.
And the ESMO guidelines provide this highly complex algorithm for designing these chemical regimens.
Let's talk about the chemo backbones.
Okay.
It seems mostly based on fluoropyrimidines, like 5-FU. But before they even give a drop of 5-FU, the guidelines say they absolutely have to test the patient for a DPD deficiency.
Yes, DPD being dihydropyrimidine dehydrogenase.
Right, which is an enzyme crucial for metabolizing 5-FU in the liver. How exactly does lacking that enzyme lead to such severe toxicity?
Well, 5-FU is an antimetabolite.
Yeah.
It mimics uracil, which is a building block of RNA and DNA, basically tricking the cancer cell and disrupting its ability to replicate.
Okay.
Normally, the DPD enzyme breaks down over 80% of the 5-FU you administer, safely clearing it from the body.
Gotcha.
But if a patient has a genetic mutation causing a DPD deficiency, they lose that clearance mechanism. So the drug just builds up in their blood.
It accumulates to highly toxic levels. It can lead to severe neutropenia, mucositis, and even lethal complications.
Wow, so checking for that first is vital.
Absolutely. Once you know they have normal DPD function, 5-FU is typically paired with other agents. Adding oxaliplatin gives you the FOFOX regimen. Adding irinotecan gives you FOFIR.
And for patients who are really fit but have aggressive disease, maybe needing that rapid conversion therapy we talked about, they combine all three into FOFOXCRI.
Right, and these combinations are potent because they attack the tumor from multiple angles.
Okay.
Oxaliplatin physically blocks DNA replication, while irinotecan literally causes fatal DNA strand breaks.
And then the oncologists layer those targeted therapies on top of the chemo, right? Like anti-VEGF agents. I think bevacizumab is a big one.
Yes, especially for patients with RAS mutations or right-sided disease. Tumors need a massive blood supply to grow, so they secrete VEGF to stimulate new blood vessel formation.
Like building their own supply lines.
Exactly. Bevacizumab binds directly to that VEGF signal, intercepts it, and essentially snars the tumor of oxygen and nutrients.
Okay, here's where it gets really interesting.
Yeah.
Because the guidelines also highlight a treatment that completely abandons cytotoxic chemo altogether. I'm talking about pembrolizumab, specifically for those patients with the DMMR or MSI-H profile we brought up earlier.
Yes.
We're talking about weaponizing the patient's own immune system, right?
The clinical data on pembrolizumab in the first-line setting for these specific tumors is genuinely historic.
Really?
Oh, yeah.
Yeah.
These hypermutated tumors produce a massive amount of abnormal proteins, which the immune system should normally recognize and attack.
But the tumor hides.
Right. The tumor cells express a protein called PDL1, which binds to a receptor on passing T cells. It essentially acts as a molecular handshake that tells the T cell, hey, I belong here, stand down.
Wow. And pembrolizumab breaks that handshake.
Exactly. It's a checkpoint inhibitor. It physically blocks that interaction. Once the handshake is broken, the T cells suddenly recognize all those mutations. The immune response is profound and often durable.
And it beats standard chemo in those specific patients.
Significantly, and with a vastly superior toxicity profile.
But for the majority of patients whose tumors don't have that specific profile, immune checkpoint inhibitors just aren't effective.
Unfortunately, no. They rely on those heavy chemotherapy backbones like FOFFX.
And that introduces a critical challenge:
Yeah,
cumulative toxicity. Because you can't just stay on intense chemo forever.
no, you can't. And if we connect this to the bigger picture, the management of metastatic colorectal cancer is really a marathon.
Right.
A patient on FOFX will eventually develop peripheral neuropathy. Oxaliplatin accumulates in the sensory nerves. The patient starts losing sensation in their hands and feet, which can become permanent.
You can't just push through that. The guidelines must have a plan for it.
They advocate for maintenance therapy. The oncologist will strategically de-escalate. After the tumor is controlled, they stop the oxaliplatin to save the nerves and transition the patient to a lighter regimen, like just 5-FU and bevacizumab.
So the goal shifts from shrinking the tumor to just keeping it asleep, essentially, while preserving the patient's quality of life.
Exactly. And when the tumor inevitably mutates again to evade that maintenance therapy, the MST shifts to a second line of therapy, then a third. It's a highly calculated game of chess.
It really is. So what does this all mean for you listening? I mean, we've mapped an incredible landscape today.
I really have.
We bypassed the blunt instruments of the past. We zoomed into the strict 48-hour pathology window. We explored how the origin of your colon, right versus left, dictates your response to drugs. And we saw how these multidisciplinary teams use local ablation and complex conversion therapies.
It's a completely different world now.
Right. A metastatic colorectal cancer diagnosis today triggers an incredibly sophisticated, highly personalized playbook.
It requires continuous adaptation. And actually, I want to leave the listener with a final thought to mull over, kind of returning to the concept of those liquid biopsies we talked about.
Okay, lay it on us.
Currently, we use them mostly for initial testing, but tumors are dynamic. They constantly mutate. As the technology to analyze circulating tumor DNA from the blood becomes faster and more precise, we are approaching a horizon where cancer care won't rely on rigid, static treatment lines.
Wait, meaning we can monitor the tumor's DNA in real time?
Exactly. Imagine a future where a simple, routine blood draw constantly dictates your treatment.
Oh, wow.
As the tumor mutates, the oncologist instantly adjusts the targeted drugs to match the new mutations. It shifts oncology away from episodic chemical attacks and towards something that closely resembles pushing a continuous software update to a patient's treatment plan.
A continuous software update to outsmart an adaptable enemy. That is incredible. Well, thank you for joining us on this deep dive into the source material. Stay curious. We'll see you next time.